no questions about any of that, we'll go ahead and get started. I don't know why the projector's still not on. Hopefully it works. Maybe it's not plugged in. There we go. Okay. All right, so today we are going to be talking about psychological disorders. I'll let you know, so today we're kind of going to go through the various psychological disorders and their symptoms, talk a little bit about their causes for the ones that are known, and then next Tuesday we'll be talking about like treatment and therapy. So you'll notice as we talk about these, I'm not going to talk too much about treatment. I might mention a couple little things, but next Tuesday will be devoted entirely to talking about treatment and therapy. I will say, I kind of mentioned this whenever we talked about social psych, that, again, my background's in cognitive psychology, not at all in clinical counseling. That's kind of the area I would say I have the least expertise in when it comes to psych. So, there may be some of you who know more about this stuff than I do, especially if you have, like, family members or things that have suffered from these psychological disorders, which is, perfectly fine. So, thankfully, we didn't get too far in. I was only one slide in before I realized it, so. Okay. So as I was saying, there's hundreds of these different disorders. There's no way we're going to get to all of them. So we're really just going to kind of highlight the ones. I'll start with the ones that are most common, and then we'll also talk about a few towards the end that are the more like severe. And then I just want to kind of set a tone from the very beginning to make sure this should be obvious. But I want to make sure we all understand that psychological disorders are a very serious, very real thing. They're just as valid and important as any other kind of illness. We tend to make this distinction between like physical illnesses and mental illnesses or psychological disorders, but really they're kind of one and the same. So there's pretty good evidence at this point that basically all psychological disorders have some kind of biological component to them, just like, diabetes or the flu or anything else. There is something that's going wrong in the body often that can be treated, with proper treatment, medication, and therapy. And so, I'll kind of come back to that theme a couple times, but I just want to kind of set that tone from the very beginning. So to start, we're going to start by talking about how psychological disorders are diagnosed, specifically using this book called the Diagnostic and Statistic Manual, or the DSM. The DSM were originally developed, I think, in like the 1950s or so there was one original DSM. But it's been updated several times. At this point, we're at the DSM-5, which really there's even like an update to that. It's called DSM-5-TR, so we're kind of at like the 6th version of the DSM. And each of those updates basically happens because there's some sort of cultural recognition that there's something wrong in the DSM that needs to be fixed oftentimes. Historically, I'll talk about this more in a little bit, but historically there's been things that have been, included in the DSM that we've decided like maybe shouldn't be in there. So we'll talk about some examples of that in just a second. But like I said, first edition was published in 1952. It gets updated roughly every 10 years or so. There is another classification system that's used more commonly worldwide. It's called the ICD, which I can never remember. It stands for the International Classification of Diseases. So that one's used more globally, but the DSM is used pretty commonly in the US and also for research purposes as well. So like I said, there's hundreds of different psychological disorders, but in order for something to be considered an actual disorder, it has to meet 4 criteria that are determined by the American Psychological Association, or the APA. So the 4 criteria: 1, it has to cause a significant disturbance in the person's thoughts, feelings, or behavior. So the person has to be acting in a way that's atypical, that's different from kind of the norm, to such an extent that it's considered significant. So that's criteria number 1. Criteria number 2 is that it has to reflect some kind of dysfunction that can be identified. So that dysfunction could be biological. Oftentimes that's going to be something, dysfunctional in the brain or the nervous system. It could be something psychological or developmental as well. So something that starts early in childhood and kind of develops over the lifespan. But there has to be some identifiable dysfunction. It has to lead to significant distress. So psychological disorders are going to have a severe impact in a person's kind of day-to-day life. It's going to interfere with their relationships, their ability to work, to go to school. So it's going to cause, significant distress. And then in addition to that, cultural, context has to be taken into consideration as well. So there are certain things that might be considered a psychological disorder in one culture, but not necessarily in another culture. So that cultural component is also very important. So if something meets those 4 criteria, then it's likely that it will get a designation in the DSM. Although, like I said, there's been a lot of updates and changes, so sometimes things get added or thrown out. So I mentioned this briefly, but historically there's been a lot of shifts in what we consider a psychological disorder, and that's often what's taken into account when they're making these updates to the DSM. So for example, in the original Diagnostic and Statistic Manual that was published in the 1950s, homosexuality was actually considered a psychological disorder, or at that time they would have called it a mental illness. And it was included in the DSM all the way up to, I think, like the DSM-IV, which was in the 1970s. So for a pretty long period of time, people thought homosexuality is basically a psychological disorder. Eventually, due to advocacy from mostly the LGBTQ community, they realized that that is not a disorder and that they should remove it. There was also, for a period of time, I think in the DSM-IV, they kind of switched it to, instead of saying like homosexuality itself is a psychological disorder, they would say like distress from homosexuality was a psychological disorder. Eventually they removed that entirely, so the DSM-V doesn't have any language about like sexual orientation being a dysfunction. Also, just like the words that are used in the DSM often get updated to reflect more, understanding in our culture. So for example, they often used to use the word retardation, which we've realized is not, a particularly great word to use. So those have been changed to things like intellectual disability. So every time there's a new version of the DSM, there's updates to that kind of language to be more inclusive, to take into account the actual data on whether something should be considered a disorder or not. So there's all kinds of updates, like I said, that happen pretty much every time. Let's see. All right, so let's start with kind of talking about the prevalence of various psychological disorders. Like I said, we're going to talk about them kind of in the order of their prevalence. This is a graph that comes from 2007, so this data is probably pretty outdated. I would say most likely all of these numbers have increased probably over the past 15 years or however long it's been. But the most common psychological disorder is major depressive disorder. And really kind of mood disorders in general tend to be pretty high up there on the kind of scale of what's common. Also like alcohol abuse and substance abuse. I will mention we're not going to talk about those today only because we've already talked a little bit about addiction. I think it was when we talked about motivation or something. So I'm leaving that out of today's lecture only because it's something we've already covered previously. And then also anxiety and sort of fear disorders are also very common. So things like specific phobia, social anxiety disorder, generalized anxiety disorder, those tend to be pretty common as well as far as psychological disorders go. So we'll talk extensively about mood disorders and anxiety disorders. And then, like I said, we'll also talk about some of the more severe ones, things like schizophrenia, for example. One thing to keep in mind anytime I'm talking about the prevalence of a disorder is this concept of comorbidity. So comorbidity refers to the fact that oftentimes if someone has one psychological disorder, they're very likely to have a second or maybe a third that's sort of co-occurring in one individual at the same time. So we refer to that concept as comorbidity. So for example, kind of one of the most common comorbidities is substance use or substance abuse. So about a quarter of people who suffer from some sort of mental illness are going to also have a substance abuse disorder as well. So there's a pretty large overlap between those two. Something else to keep in mind that's sometimes a little tricky about comorbidity is that that relationship can be true in one direction, but not necessarily in the other direction. So a quarter of people who have mental illnesses will also have a substance abuse disorder, but there's a very large pool of people that have substance abuse disorders that do not also have a mental illness. Okay, so it can kind of be true in one direction, but not necessarily true in the other direction. And comorbidities are really important to consider, especially for treatment purposes. Again, we're not going to talk too much about treatment today, but so for example, if you have someone who has a substance abuse disorder, and they're suffering from like depression or something like that, you need to consider that whenever you're prescribing them medication, because they may be more likely than other people to get addicted to those medications or abuse those medications if they have a history of substance abuse. Or if you have, comorbidity of certain disorders, a medication might help one of those disorders, but it might actually make the other disorder worse. So it's really important to kind of keep those in mind for treatment. Okay, another thing I just want to say really quickly so now I'm going to start talking about the various disorders. There's often kind of this tendency that I think a lot of people have to kind of self-diagnose, especially as you start hearing these different symptoms, right? You might hear me say a symptom of depression or anxiety disorder or whatever, and you might start to think, sometimes I experience that. Do I have this disorder? And just keep in mind, every single person on this planet definitely has at least one symptom of one of these psychological disorders. Okay, I guarantee you all of you are going to have some of these symptoms. I have some of these symptoms, but that does not mean that you have a disorder. Keep in mind those 4 criteria we talked about at the beginning. One of the major ones is that it has to be severely disruptive to your life. So everyone has some normal amount of sadness or anxiety, etc. But if it's not interfering with your schoolwork, your job, your relationships, then it's very likely that it's not a disorder. It's just kind of normal everyday life experience, basically. So resist that temptation to self-diagnose. If you really do think you have a disorder, then the best thing to do is to go see a professional, get that professionally diagnosed so that you can get treatment and deal with it effectively. Okay, so, the DSM kind of breaks up these disorders into different classes or families. So you can have multiple disorders within kind of a category. So the first family of disorders we're going to talk about are mood disorders. And mood disorders, as the name implies, is any disorder that's going to affect your mood, right? So kind of your overall happiness or sadness level. The most common one is what's called major depressive disorder. So someone with major depressive disorder, they have persistent symptoms of depression that last for, I think the cutoff is it has to be at least 2 weeks. I have notes for all these specifics because these are things that I don't have stored in my brain very well. Yeah, so you have to have persistent depressive symptoms for at least 2 weeks to be diagnosed with major depressive disorder. Oftentimes when we think about depression, probably the first thing that comes to your mind is sadness. So someone with, who's depressed, they're going to feel sad. Which can be true. Sadness is certainly a part of depression, but it's often not the most pronounced or even the most common symptom of depression. One of the more common symptoms is a lack of motivation and also a lack of enjoyment from the things that someone would normally enjoy. So if you have someone who in the past really liked sports and they liked socializing, if they're suffering from depression, then even when they can muster up the motivation to go do those things, they often are not going to find it to be as enjoyable or as rewarding as they did prior to, suffering from the depression. So there is sadness, but there's also lack of motivation. There's, kind of losing interest or enjoyment from the things that we typically tend to enjoy. There also can be kind of hopelessness. So people with depression often either don't think about the future, or if they do think about the future, they have this very hopeless view that the future is only going to be, the same or worse. They don't really have any hope that things are going to get better. And then there can also often be other symptoms that kind of come along with depression but aren't necessarily part of the depression itself. So for example, a lot of people with depression will have changes in their weight. They might either gain weight or lose weight. They'll also have sleep changes, so they might sleep a lot or they might sleep less. They might have insomnia. You can have decreases in sex drive and again, kind of just overall motivation. There can also sometimes be some cognitive symptoms as well. So people with depression might have sort of a brain fog, a harder time, being coherent, talking, things like that. The other thing to note about major depressive disorder, it's often episodic. So someone might have kind of these, severe depressive symptoms for a few weeks, and then it might kind of go away. They might start to feel better, but then oftentimes that depressive symptoms will come back. Prevalence of major depressive disorder, it's about 7% of people will experience it every year. So if you just measure from year to year, there will be about 7% of the US population. About 17% of people will experience it at some point over their lifetime. Those who have one major depressive episode are about 70% likely that they will have a second one, or recurring major depressive disorder. There's also some subtypes of this as well that I should mention. So there's like seasonal depression. I think we talked about that a little bit when we talked about moods. So sometimes people may only have these symptoms like during the winter and then they go away for the rest of the year. There's also things like postpartum depression that can be triggered from, having a newborn baby. All of the hormonal changes that go along with that and the life changes can sometimes trigger depression. So there are some kind of like subtypes. All right, the other mood disorder I wanted to talk about is bipolar disorder. So bipolar disorder is characterized by these very, significant swings in mood. Typically, someone with bipolar disorder will go from like a depressive state that will have all the symptoms I just talked about with depression, and then will swing to a manic state. And in the manic state, they often will have, it's kind of like the opposite of depression. They have extreme motivation. They become very ambitious. They want to just like do everything. They may experience like euphoria where they just feel super happy and alive and excited. They often, though, will end up making very bad decisions during that manic phase. So someone with bipolar disorder, the manic phase can often actually be a lot more dangerous than the depressive phase. So when they're manic, they might decide like, I'm just going to sell my house. I'm going to quit my job. I'm going to move across the country and start a whole new life. And then they go to try to start that. The thing about the mania is it's not going to last forever. It might last a week or a couple of weeks. So if they're making those decisions to like completely change their life, and then all of a sudden the mania stops, and they might even go back to that depressive state, then now all of a sudden they're living halfway across the country, they don't have their house, they don't have their job, and now they're in a state of depression, right? That's going to be very difficult to deal with. So the mania can often be very dangerous. People in mania often will do things like gamble away all their money. They, like I said, might sell their house, quit their job impulsively. They basically just make these really grand, impulsive decisions without thinking it through at all. They also, during that time, might be very irritable. It's different from person to person, but you can have other, kinds of mood issues like that. Let's see. So that's bipolar disorder in general. So the way I just described it is classified as bipolar 1. So bipolar 1 is where you're kind of switching back and forth from severe depression to severe mania. There's also bipolar 2, which is where someone has kind of less pronounced mania. So they might have the really severe depression and then they kind of swing back to like a baseline normal, but their mania isn't as pronounced. So that's bipolar 2 if the mania isn't quite as significant. All right. For both major depressive disorder and bipolar disorder, we know that there's a pretty strong genetic component. So these psychological disorders tend to run in families. If one twin has it, then the other twin is like very highly likely to have the same mood disorder. And then we also know that they tend to be caused by imbalances in different neurotransmitters. So particularly norepinephrine and serotonin. So again, we're not going to talk about treatment too much today, but maybe just keep this cause in the back of your mind when we talk about treatment next week. You'll notice that it reflects kind of, these causes basically. So again, just like all the other psychological disorders, mood disorders we know have a very strong biological component. There's this genetic component, and then there's also, basically things out of whack in the brain with the neurotransmitter systems that cause these mood disorders. Okay, another very common kind of family disorders are the anxiety disorders. So if we just look at anxiety disorders like as a family, it's probably the most common. So about 25 to 30% of the US population will be diagnosed with one of these disorders or will meet the criteria for diagnosis of one of these disorders. So in general, anxiety disorders are characterized by persistent fear and obviously anxiety, so kind of like worrying But the different specific psychological disorders basically have to do with like what is that anxiety aimed towards, essentially. So one of the most common ones is what's called specific phobia, which is, pretty much exactly what it sounds like. It's where basically someone has a very persistent and irrational fear towards a very specific item or object. The most common phobias would be things like fear of spiders, fear of heights, fear of enclosed spaces, fear of flying, but there's, a bunch more. So, again, this might be a place where you're like tempted to self-diagnose, like I definitely have a phobia of whatever, right? But probably you don't actually have a phobia by the DSM criteria. Because again, for it to be considered a phobia, it has to interfere with your daily life, right? So like how many of you are scared of spiders? Okay, a lot of people, right? So how many of you though, like if there was a spider in this classroom right now, like if I saw, oh, there's a spider up in the corner, how many of you would decide like you're just never gonna come to class again? Probably nobody, right? So in order for it to be considered a phobia, it really needs to be at that level where it's like, I am so terrified of this thing that I'm not going to go to class, I'm not going to go to work, I'm not going to, again, it has to interfere with those very important aspects of our lives and our relationships. And if it doesn't, then that's probably just more of like a normal, quote unquote, fear, essentially. So probably none of you have a phobia by the DSM standards, although that term phobia, like a lot of psych terms, is kind of misused in like, the lay public. A lot of these anxiety disorders, but particularly phobias, are probably caused mostly through experience and through learning. So you might acquire a phobia through conditioning, for example. So maybe when, someone was a very young child, they saw a spider, and maybe at the same time that they saw that spider, something bad happened to them. Or maybe even that spider bit them and it hurt, right? And so then you have this association like, okay, this thing causes pain, or this thing is dangerous or scary. And then that can persist, throughout the lifetime. It can also come through vicarious learning. So if you're a little kid and you see your mom come in the room and there's a spider and she starts screaming and freaking out and is terrified, then you're going to learn pretty quickly, like, okay, spiders are something scary. They're something that I should avoid. So phobias are one that seems to be learned and doesn't have quite as much of that like genetic or biological component. Where the genetic component maybe comes in is just what we tend to have phobias for. So we've already talked about this when we talked about evolutionary psych, but we're very likely to have phobias for things like spiders, but not for things like cars or cardiovascular disease. And that's, what we end up having a phobia about might be more kind of genetically based, but then actually developing that phobia comes from learning and from experience. Another very common anxiety disorder is social anxiety disorder. So with social anxiety disorder, it's kind of almost like a phobia of social settings. So someone with social anxiety disorder is going to be very fearful of, speaking in public, would be probably like their worst nightmare, but also just, going to any kind of event where they're going to have to interact with strangers, making small talk, all of those things are going to trigger their anxiety, basically. And again, keep in mind, everyone has a little bit of social anxiety. Everybody, you walk into a room with strangers, you're going to maybe feel a little bit nervous. That's completely normal. It becomes a disorder, again, when it starts to interfere with daily life. Are you skipping class? Are you not going to work? Are you not, maintaining your friendships and your family relationships, etc.? One of the kind of, I don't know if interesting is the right word, but, one of the things about social anxiety disorder is it can often put people in these sort of like self-fulfilling loops. So someone who has social anxiety disorder, let's say they decide, okay, I'm going to go out and meet new people, but I'm going to sit here for 2 hours before I go out and I'm going to rehearse every possible conversation. I'm going to think about, what are they going to ask me about and what's my response going to be? And they might kind of ruminate on that to the point that then when they go and have those conversations, they might sound really robotic and awkward because everything that they're talking about has been scripted in their head ahead of time. Or if someone says something that's way off their script, they might kind of start to panic internally and act strange because of that. So then if they're trying to make friends, but they're acting all awkward and robotic and weird, it might not work very well because the other person might sense that and might be like, okay, this person's kind of weird. I don't want to hang out with them again, right? So then it becomes kind of this self-fulfilling thing of like, oh, I tried to go out and meet people, but it went badly. So now I'm feeling even more anxious. So they can often get into kind of these loops that can kind of spiral into even more severe disorder. All right, the next anxiety disorder is called panic disorder. So panic disorder is characterized by basically having frequent panic attacks. So a panic attack, if you're lucky enough to have never had one, is basically an experience of sort of feeling like you're dying, essentially, is the best way to describe it. So people who have a panic attack, they will perceive that their heart rate has increased, even though oftentimes if you were to actually measure their heart rate, it's stable or kind of within like normal ranges at least. But they have a perception that their heart is beating very fast. They might start to feel like their chest is tightening and closing, like they can't breathe. And then they might start to think like, am I having a heart attack? Am I having a stroke? And that can often then exacerbate those panic symptoms. Typically the panic attack will last, like between 10 and 15 minutes. But while the person is having the panic attack, it can feel like an eternity, because being in that state of thinking like you're dying, obviously is very stressful. So to be considered, panic disorder, again, it has to be, interfering with day-to-day life. It's entirely possible that any one of you might have had like a single panic attack at some point in your life. I've had maybe like 3 or 4 in my entire life, but it's never gotten to the point of being a disorder because it's not chronic or persistent, and it's never like interfered with day-to-day life or functioning. Let's see. I know I haven't been talking necessarily about causes of all of these, but for panic disorder specifically, we do know that there seems to be something, again, neurological that's dysfunctional. There's a part of the brain called the locus coeruleus. I never know if I'm saying that word right because I've never heard anyone else say it out loud, but locus coeruleus. Basically, that part of the brain is important for activating the sympathetic nervous system, which if you think about the sympathetic nervous system, the fight or flight response we've talked about multiple times in this class, that's kind of what a panic attack is, right? It's like overreaction of that sympathetic nervous system. So people with panic disorder probably have some kind of abnormality in that area of the brain. And then the last anxiety disorder we'll talk about is called generalized anxiety disorder. And this is where a person basically just has, like the name implies, just kind of anxiety about everything in general. So with all these other ones, specific phobia, social anxiety, those are kind of towards something specific. Even panic disorder, some people classify this as like fear of dying a little bit. And that once you start to have just a few of those physical symptoms, that kind of fear of death kicks in and makes you feel like you're having, it basically creates the symptoms of panic attack. But with generalized anxiety disorder, it's like everything. So people with this disorder just constantly worry about every little thing. So they might worry, they might have social anxiety, they might worry about social interactions, but they also worry like, oh gosh, did I turn the oven off? Did I, close the doors and lock them whenever I left the house? They worry about the future a lot. They worry about, am I going to keep my job? Am I going to do okay in school? So again, all of those thoughts that I just said, probably all of you have had those thoughts at some point in time, totally normal and healthy. Again, it's a disorder whenever it becomes dysfunctional to the point that it interferes with, our day-to-day life. Often the things that they worry about are pretty pointless. They're things that are like kind of minor, that in the grand scheme of things, if you just stop and take a step back, don't really matter. And they also often worry about things that are completely outside of their control. So that worry doesn't really help anything. It doesn't go anywhere. It doesn't motivate them to actually do anything. They just kind of spend a lot of time like ruminating on those worrying, anxious thoughts.